So the KEYNOTE-966 study was a large, global, randomized phase 3 study looking at biliary tract tumors, which historically are a very difficult group of diseases to treat. The standard backbone has been gemcitabine and cisplatin for more than a decade, and the benefit is real but marginal. And we've been trying to improve on that, and KEYNOTE-966 looked at adding the PD-1 inhibitor pembrolizumab to chemotherapy, and this is one of the two large phase 3 studies looking at checkpoint inhibitors with gemcis that met its primary endpoint of improving overall survival. And now what we've seen with longer-term follow-up, the survival advantage is very stable. We see that there is a tail to the curve, which we've seen with many checkpoint inhibitor studies, where about 15% of patients are now having longer-term survival, now out at 3 years. We've seen that the objective response rate of 29%, which we see with gemcis pembro, which is very similar to the control arm of just gemcis, but the difference is it's very durable. The durability of the responses we see with pembrolizumab are greater than with gemcis alone, and we see that at this 3-year mark, about 24% of patients still have their ongoing response. So with longer follow-up, again, it's an incremental improvement for these patients. The hazard ratio was 0.83 as far as a magnitude of benefit, but in the context of where the field has been, this is a step forward and is probably now the standard of care for most of our patients. So really there's no surprises when we look at the side effect profile. Gemcitabine and cisplatin are cytotoxics, and we see cytotoxic type of side effects, bone marrow suppression, fatigue. We need to watch for neuropathy and kidney insufficiency, but it's generally well tolerated. The new part of this is pembrolizumab, and really the incidence of immune-related adverse events with the combination is really no different than we see with pembro alone. Some increase in thyroid dysfunction, some increase in rash from the pembrolizumab, but as far as serious immune-related adverse events, those are fairly uncommon. I think the addition of drugs like pembrolizumab and durvalumab to chemotherapy in this disease is a step forward, but we have a lot of work to do. Median survival is still only about 13 months, 12, 13 months, and we want to do better. I don't know that we're going to find a biomarker so quickly for the patients who do better with IO than without. That's been hard in many diseases. I think probably a big opportunity will be in the second-line setting. Right now there's a number of molecularly targeted agents for patients who have specific alterations, but that's a minority of patients. So, I think we still have unmet needs, and really it'll probably be moving in new agents into the space. Perhaps antibody-drug conjugates, I think, are actually an interesting group of drugs to move into the space, and those data are starting to be generated.